So now I want to shift gears a little bit to talk about the current standards in biomarker testing. So the current recommendations by the NCCN guidelines, which are the national and sort of international guidelines that a lot of centers, both in the US, Canada, but also worldwide, will follow. Biomarker testing that is recommended for non-small cell lung cancer includes a whole host of essentially driver alterations like we described earlier, including the PD-L1 percentage testing to dictate therapy. And again, this is important because based specifically for the genetic alterations, based on the genetic alteration identified in a particular tumor, we will have different therapeutic options available for our patients. Again, this is just showing some of the therapies that are currently available and used in standard practice. But again, just to drive home the point that this is very specific and the biomarkers will be helping us to identify specific therapies for each of the patients that we see in our clinics. The best practices for advanced non-small cell lung cancer, essentially at diagnosis, we would definitely want molecular profiling. Reflex testing is usually preferred, so to make sure that the testing is correctly implemented. And essentially, it could be on tissue biopsy, if available, to identify standard of care therapies. When tissue biopsy is not available, as I mentioned, ctDNA, circulating tumor DNA, or liquid biopsy would be preferred, again, to identify any particular therapeutic target. If we are able to identify that even on liquid biopsy, we would generally treat with standard of care therapy based on oncogenic drivers. If we are not able to find any genetic alterations in both tissue and liquid biopsy, generally we tend to think of those cases or tumors as being non-oncogene driven and will usually have some sort of treatment with chemotherapy or immunotherapy or both. This is also important in the setting of advanced non-small cell lung cancer where the tumors have relapsed or are refractory. Again, the idea with the molecular testing, either with liquid biopsy or tissue specimen, being to identify the resistance mutations, particularly for that particular tumor. If we are able to identify a particular resistance mutation to which we may have therapies today, then those would be the standard of care therapies for those oncogenic drivers. If not, then again, if tissue biopsy has not been established for the relapsed refractory cases, it is important to do that in order to identify whether there has been a change in histology or some other information that we may have missed from the liquid biopsy alone.